Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We've got quite a lengthy procedure for you today. It's just shy of half an hour, and it's of a patient who actually attended today, and they travelled all the way from Blackpool. So for anyone who's not fully aware of the landscape and geography of the UK, Blackpool, and my clinic is based in the Midlands, in a city called Leicester. So it's in the centre of the UK, or England, should I say. And Blackpool is classified as being northwest. And in terms of their commute, it was probably about 2 hours and 45 minutes each way, so about 5.5 hours in total. And the reason why they attended was they regularly have their ears cleaned, local to them, but they always feel that their ears are not fully cleaned. And there's patient's son, he actually owns a radio station, so he obviously probably heard me on radio in the past and advised his mother to come and visit me. And so when the patient attended, they wear bilateral hearing aids, and so we examined their ears. And to be fair, I did explain to the patient that the audiologist or the specialist that they've been seeing have in essence done an okay job, because they've cleared the auditory canal, so the eardrum is visible, and anything more than that becomes more of a non-routine case, which is what this is. So now it did make a huge difference me removing this, and a lot of this is also fungal infection. And so once we've removed this, you may have seen right at the beginning, there's a few fungal spores there sitting on the surface of this dead skin. So all this around the edge is all debris and dead skin. You can see how old and dark it is. If you've got a fungal infection, it can be quite dark as well in appearance. And it's a very, very difficult thing to remove, and hence why I can understand why the previous specialist may have not attempted it, because it does require a lot of skill really and experience to do procedures like this. There's no way I wouldn't have been able to do this when I first started. It's just way too complex, because here we are literally gliding across the canal wall and also the eardrum, and the ear canal, as I've discussed on many occasions, extremely sensitive, and I'm saying that firsthand because I've experienced trauma to my own ears. That's by my own mum as well. My mum, growing up, we are from obviously Asian background, Asian descent, and heritage, and it's almost an initiation rite that all of our ears need to be poked and prodded by our mothers with a cotton bud. And I still remember the agony I was in on one occasion on my left ear. So that's always stuck with me. And I know sometimes people say, "Oh, just get in there and do this and do that." I've got to have the patient's best interest at heart. They're not asleep, they're awake. And if I was doing to your ear what you're asking me to do to other people's ears, believe me, you wouldn't be happy with me. So we've got to tread with this with extreme caution. And what I'm basically trying to do at the moment is find somewhere, anywhere, where I can start peeling away. But it's just too stodgy, it's too wet and loose. And thus far, I'm not able to peel the skin. You can see it's just really soft and wet and loose. However, we do succeed in the end, and I start peeling a lot of this away. Some of it I will have to remove it like I am now. I'm just hovering over with this with the suction probe, but you can see the eardrum is visible, but there is a layer of dead skin there. So I think this is when we start making progress. So I'm using the fine end, and I'm just gently gliding across the canal wall. We're on the bony part here, so I've got to be careful. I'm just looking for the edge of some of this skin, which I can then take advantage of. And you can see it's a bit green there. So these are all hallmark signs of a fungal infection. So we have provided some treatment for the patient, some antifungal eardrop solutions. You can get these over the counter. And another hallmark symptom of a fungal infection is extreme itchiness, or what we call psoriasis. And this patient experienced that quite a lot recently. There is been unbearably itchy. So this is where we're beginning to make some headway. So this dead skin, it's kind of moist and soggy, and it's going to now peel away slowly off the eardrum. So already it's looking a lot cleaner, a lot healthier. The underlying canal looks okay. There's no inflammation there. There's no otitis externa underneath. So it's all superficial otitis externa. We call it otomycosis otitis externa. So otitis externa is an umbrella term given to an infection or inflammation of the ear canal, the outer layer of the eardrum, and also the external layer, the pinna. That's the cartilage on either side of our heads that look like a satellite dish. That they collectively are known as the outer ear. So beneath all this dead skin and debris, the ear canal looks really healthy, and so does the eardrum. So I'm just gently approaching the eardrum here. Now, what's interesting is if you watch my other YouTube channel, I'm going to be uploading, or may have already uploaded by the time this video has been uploaded, a skin peel that I performed using the Waxscope, and it's a completely different view, different optics. The case was also different. The ear canal in that case was extremely narrow. It's probably more complicated, that particular case, because of the anatomy of the ear is very narrow and bendy. But in both cases, obviously the view's very, very different. So, but in both cases, we're able to succeed and remove all the skin. So the bulk of the ear canal is now free of all the debris that was sitting on top of it. This particular part of the ear canal where this dead skin is, it wasn't peeling away. It was very wet and macerated. So what we mean by macerated is if you can obviously macerate fruit as well. It's when it's become soft, and in the case of dead skin, if it's exposed to a lot of water, and this patient does get water into their ears, they go gym on a regular basis, and they swim a lot, so it just provided them with some strict water precautions to avoid water going in, so most namely some swim plugs. You can get custom made ones that fit your individual ears, or you can get some over the counter. The over the counter ones, they're hit and miss. There's some people that work really, really well, others that don't. And warm, moist, dark conditions are the perfect environment for fungi to flourish, and also bacteria. So it's a perfect incubating environment. So we can't really help the ear from being dark because it's an internal orifice, albeit with a cul-de-sac, that being the eardrum. And the warmth is obviously governed by many factors, your environment, whether you wear some sort of plugs or hearing aids in your ears, they can all create sweat and humidity. So this patient does wear hearing aids as well. And of course, wet, so if you go swimming, or you duck your head inside the water when you bathe, these are all going to be contributing factors to developing an infection in your ear. And this patient, they previously, many years ago, used to have their ears irrigated, but they had to stop because the irrigation process itself always left the patient with an ear infection. So this is why they normally have regular appointments at the hospital to have this cleaned. But on this occasion, they decided just to visit myself, just to have a proper, what they call a deep clean, I think she called it. But when the patient arrived, I had to just give realistic expectations, because when I did look at the ear, I thought, oh God, this is not as simple as it looks, because I just don't know how thick that layer of debris and dead skin was. It's all over the ear canal. The entire ear canal was covered in it, and so was the eardrum. And these are probably these procedures are the ones where you can potentially cause a lot more harm and damage. So making good headway. There's a couple of comments, I think yesterday, about the audio being very quiet. So I use this. I'm using the same device in the same setting, so I apologise if that's happening. I know a lot of other people comment, or one or two commenters back said they didn't have any issues. So I'm not sure what caused that. But no, I try to, when I narrate, do it in the same environment. So I either do it at the clinic, or I do it from home, and all of the editing and narration is done on my smartphone. So I've got an app. It just saves me a lot more time. Previously, I was doing it all on my PC, and I'd be at the clinic until the early hours in the morning sometimes. So doing it on the smartphone is just a lot quicker because I'm using the phone to actually perform the procedure. So I don't have to upload the video onto my PC, which can take a long time. It's already stored on my phone, and then I've got an editing app, so it works really, really well. And obviously, because it's on my phone, I can take it home and do it at home if need be. So hopefully this audio is coming through a lot clearer and better. So I'm just trying to remove as much debris as possible. We don't want to take any risks. I did say to the patient, if at any stage I felt that I'm potentially going to be causing injury and trauma to the canal, we're going to stop. But I think we've done a good job. You can see the difference. So maybe I should have provided a before and after still image, but it's a huge difference. You may just want to rewind. Just a bit of debris at the entrance, so you remove that. So when you peel skin, there's two ways you can do it. The primary concern for me today is to clear that eardrum, and sometimes you can go directly to the eardrum, or sometimes you approach the eardrum by peeling the canal walls first. It's not a set rule though. It's sometimes when you're in someone's ear and there's a bit of skin, you start peeling it from the entrance and it goes all the way to the eardrum. And you think, yeah, great. Sometimes you do that and you're just peeling skin away from the canal wall. It doesn't affect the eardrum. And this is what really matters. If this patient wants to hear again, of course they've got itchiness as well. We want to address that too. But my primary aim is to ensure this patient can hear better. This is their right ear. This is actually ended up being slightly more complicated, and I just had to put some drops in here straight away. So that's just me vacuuming the drops. So I'm just commencing with a full zone suction probe. So the internal diameter of this is about 1.7 millimeter, whereas the fine end it's about 1.1, I believe. It's almost double internal diameter, so that creates more suction power, but also more noise. With dead skin and debris, sometimes it can clarinet. Clarinet is when you're vacuuming dead skin or debris and the skin violently flaps at the tip of the suction probe, and it emits a very loud, high-frequency squeal, which is not only deafening for the patient, but also for myself. But I'm actually trying to... I've submitted a patent, actually, on a new type of suction probe. So with the fine end, one of the negatives of the fine end is that although it reduces suction noise and also suction power, it keeps getting blocked. So I've come up with a very neat concept, which I'll disclose in due course. I'm just getting some prototypes made where I may be able to solve that problem. So I don't want to say anything more at the moment though, until, although the patent has been submitted, I'm just actually waiting some CAD scans and some prototypes, and then I can confidently speak about it in more detail. Just to give everyone else an update, I know people have asked, I'm still waiting for the instruments. They're in manufacture, so it's an injection mold tool that we're having made, and I'm told that it's on course to be completed on the 1st of November, and then we'll get some samples made from the tool of all the instruments for my evaluation. So hopefully the first week of November I'll be able to actually take some photos maybe and use them in some procedures. So I'm just busy in the background getting all the regulatory documentation in place. We're nearly there with that. So with medical devices, there's a lot of hurdles you have to cross over, quite rightly, because they are medical devices that can potentially cause risk and injury and trauma to a patient. So there's a lot of documents involved, a lot of post-market surveillance, quality management systems. You basically have to write, it's called a technical file, and you basically have to explain everything that you've done, every step of the way, all the materials, the biological safety data, the manufacturing process. We have to do a risk analysis, which is about 54 pages, I think. And yeah, it's a lot of work involved. So we're nearly there. So with the Waxscope, that's all done now. With the Speculi, that was just completed as well. It's just the instruments, we're nearly there, so that's good news. So just on top of the eardrum. So already at this stage, the patient can hear a lot better. But there's still a lot of debris around the edge. So I know the patient will be watching today, so I hope you're happy with the service and you're able to hear a lot better, and you've been able to get the drops I mentioned, and we've discussed the long-term plan strategy as well, and for you to visit in the future if need be. And also I hope you got home safe. So it's a bit of a drive for you today. So the ear canal's revealing itself more and more. And this is, for me, this is why an endoscope is so good for earwax removal. The view it provides is just incomparable. And I'm saying that as a developer of the Waxscope as well. The Waxscope has different optical characteristics. It's more like a microscope. One of the negatives of perceived negatives of an endoscope, which is something that I had to challenge the status quo on, when we first introduced endoscopic earwax removal in the UK, probably 2015, that's when we really made it commercial and pioneered it in the UK, was that some people said, you can't get depth perception with an endoscope. And I think they're just a bit, the point that they're making I understand, but they weren't quite accurate. So when you use an ENT microscope, it's almost like a periscope in a submarine. You've got two eyepieces that are converged to look at an object, and when you've got two eyepieces that are converged, it provides you with what we call binocular or stereoscopic vision. So when you look through binoculars, for example, you can gain depth perception because you're looking at an object in the distance with both eyes, and the information from both eyes is then sent to the brain. That provides you with binocular vision, and you can get depth perception. You guys can try it yourselves. So, I think I did this on a recent video. If you keep both eyes open and one hand stretch out in front of you as far as you can, and just lift one finger up, and then with your other hand, with one finger, try and touch the tip of the finger. When you've got both eyes focused on that finger, you'll be able to judge the distance, so it'll give you depth perception. But if you close one eye, it just becomes a tad more difficult. So when you use an endoscope, you're not using binocular vision or stereoscopic vision. You're actually looking on a 2D screen. Now, you can get 3D endoscopes now where surgeons sometimes use it, where you wear 3D goggles, so you can visualize it in 3D. However, once you experience with an endoscope, you actually develop depth perception using monocular vision. So it's not that you can't get depth perception with an endoscope, it's just a different method. And of course, ENT surgeons perform endoscopic ear surgery, and so do other surgeons. So, and they're probably a lot more dangerous than what I'm doing with earwax removal. They're in people's, internal organs and sometimes their brain as well. I'm sure they wouldn't be doing it if they weren't able to judge distance or depth. And it's just a different mechanism. And with an endoscope, because it provides you this wide field of view, you gain depth perception by looking at different landmarks in the ear, for example. So, for example, one of the things that you guys will all know, at the entrance of the ear canal, that's where all the hairs are. So when you see hairs, you look at the ear anatomy, you think, okay, this is near the entrance because you've got the hairs. Then you've got the first and second bend in the ear canal. Then you've got the isthmus, which is a narrowing just in front of the eardrum. And the ear canal widens. You've got the eardrum itself, obviously. Then you've got shadows and contours. And then you've got a phenomenon called motion parallax, The best way to describe motion parallax or depth perception is if you're on the motorway or highway in America and you look out the window at all the cars, and you're on the slow lane and you're looking at all the cars whizzing past you, and then in the distance you may have a building there very far in the distance. The cars adjacent to you will go past very, very fast, whereas the building in the distance will go slowly, and that's called motion parallax, and that helps you gain depth perception. Also with the endoscope, the closer you go to an image, you'll get more reflection and the image gets bigger and more focused. So again, that's another method of gaining depth perception. With the wax scope, you gain depth perception with the wax scope, but when you see things in focus, and I've mentioned that in my other video, my other YouTube channel, the links in the description. So with the wax scope, just say I'm looking at the eardrum and it's not in focus, well, I know that's going to be hard to judge the depth. But once I've got the eardrum in focus, and I'm just working on an autofocus feature for that, where you can just double tap the screen. But when it's in focus, well, you can gauge the depth perception. So if you've got a bit of wax on the eardrum, and on that particular case, I was peeling dead skin off the eardrum just like I was here, and also off the canal walls. When you see the object in focus, and you've got your depth. So it's just different cues, really. So we're nearly done here. This is a bit of a tricky bit. It was just a bit of a blind spot. You can see the cartilage in front that's hiding it. And I don't want to scratch the ear canal, so we're just trying to hover over. It's like that game of operation. I've made reference to that in previous videos. But the underneath the ear canal, as you can see, it looks very healthy. It's not agitated, it's not inflamed, there's no edema. And there's just a bit of dead skin superiorly. Now, sometimes this can be really, really difficult to remove. I did pre-warn the patient that if it gets uncomfortable, let me know, but it was fine for her. So to see the patient stay very still for me, which they're aware. I think, memory serves me correct, we got this out for us, so let's have a look. You can see the angle of the suction probe, it's kind of angled upwards, there's a little kink there, and that's allowing me access to the roof, the superior part of the ear canal and the eardrum. And it's just a bit of keratin anteriorly, so this is the anterior recess. You can see the ear canal narrows inwards and then it goes back out, and it creates a little crevice here, a little recess. We call this the anterior recess because it's the front. And with an endoscope, you're able to visualize this. With a microscope or the wax scope or most other visualization methods, it'd be difficult to visualize the anterior recess. Just a bit of annoying skin here, so I just want to get that out. We did in the end. Just giving the suction probe a little shake. Again, I'm just hovering over. And this is the inferior recess. As the ear canal approaches the eardrum, when it narrows, when it widens, not only does it widen anteriorly, but it widens inferiorly. We call that the inferior recess. I think I managed to get this actually. And again, this is not something that I would have done when I first started. It's taken years and years of experience and know-how and confidence as well. So anyone who's new to ear care, who's suitably qualified, mind you, it takes time, it takes practice, but coming from a healthcare professional where you've got all the prerequisite skills and knowledge and experience with ears already, all this knowledge and clinical experience and theoretical knowledge will all pay you dividends. It's all relevant. I rely every procedure I perform, I rely upon all my years of experience and knowledge and expertise in dealing with ears. You become intimate with ears. You learn and you practice day in, day out, and every day you learn something new. And that's I'm guessing that's with every single job. This part was a bit tricky to remove. The skin was a bit more adhered, but I think we managed to get it. And again, you can see the way I've angled the suction probe, where you want to avoid digging in. So we're gliding it, but with the angle of the suction probe away from the posterior canal wall, so that's the back part of the ear canal. So you're minimizing any trauma there and abrasions. If it was angled in the opposite direction, you're almost stabbing into the canal wall. Here we're just using this angle, this technique, you're just gliding. Still is tricky, mind you, but the patient finds it a lot more comfortable. It's like sticky tape on a piece of paper. We're trying to peel it away but without damaging the paper. So it's a very similar thing that we're trying to do. Now remember, the ear canal itself, the height is roughly 0.7 to 0.9 millimeters, and the width between 0.5 to 0.7. So that was all done. So guys, just have a read through. This is of an audiology colleague of mine who contacted me, and they suffer from earwax, and unbeknown to them, they went to a high street hearing centre to have their wax removed, and the procedure didn't go to plan, and the person who treated the patient said that everything was fine and they shouldn't worry about their symptoms. But it's only after the procedure that the audiologist realised that the person who performed the procedure was actually the receptionist of this hearing centre, and they've got their own otoscope and they examine their own ears, and of course they've still got earwax. At the very least, the receptionist who performed that procedure, given the patient's symptoms are unilateral, and it just mentioned pulsatile tinnitus and dull hearing on one side, it should have been an onwards referral to ENT. But hey, that's where we are in the UK. Take care, guys. Speak soon.